Hi, I'm Katie Robinson. Today you'll hear from Eyrika Pack, Emily Sherwood, Amy Freund, and me as we discuss attachment disorders and their relevance to the counseling profession. After an introduction, Emily will share information about how attachment disorders are addressed by mental health counselors. Eyrika will discuss how multicultural factors play a role in attachment disorders, and Amy will conclude our presentation with the biblical relevance of attachment disorders, followed by an information on the future of attachment theories. Attachment is a relationship that is formed between an infant and its primary caregiver, usually the mother. However, the main factor in attachment is having a solid and stable emotional relationship with a caring person who can also be the father, a grandparent, or another person that provides the stable relationship. Mary Ainsworth studied attachment and developed a procedure known as a strange situation. During the strange situation, the attached adult enters the room that is not familiar to the baby, where there's also an unfamiliar adult there to observe. The caregiver leaves for a short amount of time, and then they are reunited. The response from the baby is what determines the primary form of attachment. The first form of attachment is secure, which is the healthiest and most common form of attachment. It's characterized by the baby being upset when the caregiver leaves, but wants to be with the caregiver when reunited. The second form of attachment is avoidant, which is the first of the three forms of insecure attachment types. In this form of attachment, the baby is upset when the caregiver leaves, but upon return ignores or disregards the caregiver. The next form of insecure attachment is resistant. In this form of attachment, the baby is upset when the caregiver leaves and stays very upset. It's harm to calm the baby, who may also seem to be angry. The final form of insecure attachment is disorganized or disoriented attachment, which is the most uncommon of the four attachment types, which usually includes only 5 to 10% of infants. In this form of attachment, the baby is confused when the caregiver leaves, but upon return still seems confused and does not seem to understand what's happening. Attachment disorders were formally defined as disorders in the DSM-3 in 1980. Today, the DSM-5 provides two designations, which are reactive attachment disorder, also known as RAD, and disinhibited social engagement disorder, which is also called DSED. Both are classified as trauma and stressor-related disorders. Children between 9 months and 5 years present different behaviors for each classification. Those who are classified as having RAD exhibit emotionally withdrawn behavior from others and rarely look to their caregiver for support when needed. Those classified with DSED behave very differently from reactive attachment group. This group is described as being overly social and overly friendly with strangers. They do not return to their caregivers at any point to check in or see where they are. Children in this group will sometimes even be willing to go off with a stranger or someone who is not familiar. Adults with attachment disorders may have a dual diagnosis of different addiction and eating disorders, as well as borderline personality disorder. Those who present as having a obsessive compulsive disorder may also have an attachment disorder. As we move on, Emily is going to discuss how attachment disorders are addressed by mental health counselors.
Thank you, Katie. My name is Emily Sherwood, and I will be discussing the assessment and treatments of attachment disorders. The first step a counselor takes when presented with a child who is demonstrating signs of RAD or DSED is to perform a full assessment and evaluation of the severity of the symptoms displayed and aids them in seeing if the child matches the diagnostic criteria as laid out by the DSM-5. When conducting this assessment, the counselor will look at the child's background to see if there is a history of foster care, adoption, or institutionalization as often seen in foreign countries. Having a history of this manner has been seen to increase a child's likelihood in developing RAD or DSED. However, there are many other factors besides that plays a role in this as well. A counselor will also observe the child's attachment behaviors when around a caregiver, as well as when separated from the caregiver with a stranger being introduced. This gives the counselor insight as to what a baseline behavior for the child would be in this situation. If there is extreme withdrawal or indiscriminate behavior being displayed by the child that is indicative of RAD or DSED may be involved in the child's behavior. When RAD and DSED are suspected to be a force behind a child's behavior and methods of intervention have been successful, a counselor will continue to monitor the child's behavior because there are instances in which impairment of family and social relationships are still seen due to another underlying cause that has manifested due to the attachment disorder. The counselor's main concern throughout this process of assessment is to establish if the current situation the child is in provides a sense of safety. In order to effectively aid the child in overcoming their current insecure attachment and creating a new, more secure attachment, the child must feel and know that they are safe at all times. After a full assessment has been performed and a diagnosis has been made, the counselor will begin treatment of the attachment disorder. This will often involve making sure that the child is provided with a caregiver that is sensitively attuned and responding to the child, aiding in the child's ability to develop a sense of security. To achieve this, the counselor will work with and through the caregiver by aiding the caregiver in learning how to establish positive interactions with the child, and then can work with the caregiver in the sense the counselor is able to give the caregiver techniques to use in working with that child. So, in this instance, the caregiver becomes like a co counselor. The counselor will often work with the caregiver and child through a dyadic form of counseling, in which the counselor and dyad focus on the caregiver's and child's perceptions of each other, and when necessary, work on correcting observed emotional patterns between the two. When the counselor establishes that the environment the child is in is not capable of providing a sense of security, sometimes the best course of treatment is to remove the child from that situation and place them in an environment where their emotional and social needs are met. In instances where there is a comorbidity between DSED and oppositional and/or aggressive behaviors, a counselor will use evidence-based treatments, which usually involves parent-child interaction therapy or multisystematic therapy. All of these are the main forms of treatments for attachment disorders. Currently, there are no psychopharmacological treatments for these disorders, but those forms can be used in the treatment of comorbid disorders. Finally, when providing treatment, the counselor must ensure that the interventions being used do not warrant physical restraint, coercion, reworking of the trauma through rebirthing therapy, or promotion of regression for its reattachment. Those methods are profoundly ineffective and cause more damage to the child, in extreme cases, even death. This concludes this portion of our presentation. Eyrika will be presenting the next portion.
Thank you for that, Emily. My name is Eyrika Pack, and I will be talking about attachment disorders amongst a variety of populations. I was able to find a variety of studies done on attachment within different cultures. The first, I looked at low-income, abused, suicidal African American women who felt close to and could depend on others in their lives. They were approximately half as likely to report problematic substance abuse. So the study showed that these women who felt securely attached to people in their lives were half as likely to turn to drugs, alcohol, or some other substance because they specifically felt like they had someone to rely on. I found that interesting because of their situation. They were in an abuse situation, they were suicidal, they were very low. But because they felt like they had others in their lives, they didn't turn to substance abuse on top of everything else that they were going through. The next study we looked at was 2/3 of a sample of children in northern Germany were found to be insecurely attached, and half of those children were described as being avoidant. Now, that same study was actually done in southern Germany as well, and yet the results were not the same. So the German parents actually encourage early self-sufficiency. But what happened was that because of this early self-sufficiency, the children ended up having poor peer relationships and had an increased dependence on their parents. The next study was one done in China, which shows extended families play a significant role. However, in the Western model of attachment, the kids would be labeled insecure attachment. And so when they looked at children with their parents only, perhaps the parents weren't there. They were working, they were out doing other things. And yet the extended family, the grandparents, the aunts, the uncles, all these different people were involved in the children's life. But the study doesn't look at the extended roles of families. It only looks at the parent-child relationship. And so because of that, these children were labeled insecure attachment. Again, we look at another Asian country, in Japan. So this culture views dependence more positively. And it is actually encouraged versus Americans who value independence, right? And so this study showed that children in America, it would look like these children are dependent, and perhaps insecurely attached because of that dependence. But in Japan, dependence is actually a cultural thing, that it's a community where they rely on each other, they help one another. It's not all about self and getting somewhere. What I noticed as I was going through all of these different studies is on several occasions, the people conducting the studies realized that there was a bias. And that bias was that these studies are made from a Western point of view, how we as Americans define attachment. And it looks very different in other countries. Attachment, family, community, all of these things look very different outside of America. And yet we label these children and their families based on an American point of view. And that would be getting our children to have autonomy. A study was done on sexual minority youth. And as one would anticipate, those who have insecure attachments are less likely to communicate their sexual orientation versus those who have a secure attachment. Next, we looked at borderline personality disorder and how it's connected to disorganized attachment. A study looked at attachment in a borderline personality disorder patient and showed how the patient's traumatic childhood actually led to a mental illness. And as you can see, attachment affects each person individually, but can also have an effect on our marriage. How one spouse experiences attachment directly affects how the other spouse feels about their own psychological health. And now on to Amy.
In conclusion for our group project, I will summarize the relevance of attachment theory in relationships throughout an individual's life, including a relationship with God, giving examples from the perspective of a biblical worldview. Additionally, we'll look briefly at the importance of growing research in attachment theory in our future as professional counselors. As we have discussed, attachment theory is a framework for understanding social emotional relationships in early childhood and its consequences for development through the lifespan. A large body of research supports the concepts inherent to attachment theory. Consequently, a secure attachment is an advantage for a lifetime. John Bowlby argued that the early interactions with the attachment figure lay the foundation for what he termed internal working models of self and others in relationships. These working models are believed to underlie individual differences in attachment security and serve as templates from early experience that guide our perceptions and behaviors in future close relationships. As mentioned earlier in our presentation, there are 4 patterns of attachment in infants, and 4 corresponding attachment behaviors are found in adults. The adult patterns are classified through an assessment tool in a clinical setting, the Adult Attachment Interview, or the Attachment Projective Picture System. These 2 instruments activate a person's early attachment experience that developed out of their relationship to their primary caregiver. You can see the correlation between the child and adult attachment behaviors on the table within this slide. A secure or autonomous attachment in an adult is characterized as someone who is flexible, self-reflective, and can value their experiences both positive and negative regarding childhood. The 3 insecure attachments in a child have correlating patterns in adults. Dismissive attachment in an adult is someone who's likely to minimize emotional significance and insist on lack of recall. They may have gaps remembering specific childhood memories and idealize their parents without clarifying reasons, making remarks that they've been rejected by their parents but claim not to have missed any parental support. Enmeshed attachment is the adult whose past intrudes with their present emotional state and is prone to struggle with intense idealization with parents. Their parents were characterized by making them feel guilty when they tried to be independent. Lastly, the unresolved attachment in an adult is characterized by incoherent narrative style, particularly around areas of grief or trauma with lapses of reasoning and monitoring. What we see in all four attachment patterns is that a parent's ability to balance intimacy and autonomy, support and independence, has a major influence on their children's ability to cope with stress. According to attachment theory, the main cause for development of disorders is the fear of abandonment and the feeling of vulnerability when the primary caregiver is not available physically or emotionally. Alan Shore, an American psychologist and researcher in the field of neuropsychology, believes that the security of the attachment bond is the primary defense against sociopathology. While those patterns we've discussed remain mostly rather invariant, they can still be influenced by a stable and healthy relationship towards someone such as a partner, psychotherapist, and perhaps most importantly, God. A secure relationship with God, partner, or therapist has profound therapeutic influence. This can contribute a shift in the internal model from insecure to secure. Over the years, there's been research applying the principle of attachment theory to the concepts of God. This seems natural since the function of an attachment is to place us in the presence of someone who can help and enhance our survival. In the same way that the securely attached child is free to play and explore his environment, studies have indicated that securely attached people with theological interest and who perceive God as a secure base were more likely to be able to consider a wide range of theological ideas. These securely attached people also showed greater tolerance with people who have differing views. We find comforting scriptures that affirm this truth about God. The psalmist describes God as our refuge and strength, a very present help in trouble in Psalm 46:1. Paul writes of how neither death nor life, angels or rulers, things present nor things to come, nor powers, height, depth, or anything else in all creation will be able to separate us from the love of God in Jesus Christ our Lord in Romans 38 and 39. On the human side, the incarnation shows us that God himself took on the very same kind of body, and along with it, the same kind of mind and relationships with family and friends that give rise to human attachment patterns. There is something wonderful in God entering the world as a baby who no doubt formed attachment relationships with his parents and grew to have strong friendships with his disciples. There is also something terribly human in the fact that on the cross he was abandoned by his closest friends and completely separated from his own Father. It means that Jesus Christ knows, not by doctrine, but by experience, the joy, love, pain, fear, and sorrow that accompany our attached relationships. It means that when we feel abandoned by God, God himself understands. Through the relatively new study of neuroplasticity, we understand that our brains are more well equipped for change than was previously thought. The rapidly expanding field of neuroscience is constantly highlighting the importance of human relations. There's a growing awareness that our emotional connectedness with others is vital to both our mental and physical health. Attachment theory is receiving more attention from research in neurobiology and has been successfully applied to research in the psychology of religion. What infants understand cognitively and experience profoundly influences later socialization and spiritual expression. Research has shown that it's possible to move from an insecure to an earned secure attachment style, and that previously insecure attached parents can raise their children with secure attachments. All of us can create new neural circuitry, pathways, and networks that allow us to relate moment by moment in new, healthier, more resilient ways. This development in attachment literature gives us hopeful insight for applying these principles in a clinical setting, particularly for ourselves and our clients through our relationship with God. This concludes our presentation. Thank you.